So the next speaker will be Dr. Steve Bender. He is a clinical professor at Texas A&M School of Dentistry in Dallas, Texas, and he also serves as a director of the Clinical Center for Facial Pain and Sleep Medicine at TMU. He has a diploma of AAOP and a fellowship of AAOP. He also a member of American Headache Society and International Academy of Oncology and American College of Dentistry. He earned his DDS at Baylor College of Dentistry, Dallas in 1986. Prior to his joining being an orofacial pain specialist, he practiced as general dentist for 12 years, and he did his orofacial pain and TMD training at University of Florida. From 2000 to 2015, Dr. Bender had a private practice limited to orofacial pain and sleep medicine, and since 2016, he served as a full-time faculty at the TMU School of Dentistry. With that, let's welcome Dr. Bender.
Okay, so mostly people here are general dentists, correct? Good, thanks for coming. So I am going to talk about primary headache disorders. I don't guess that's going to work. No financial disclosures. Medications that I might mention could be off-label use. In other words, we use a lot of stuff in orofacial pain, a lot of stuff in headache medicine off-label. In other words, we're using it for rationale independent of its FDA approval. So this will be a little bit of a review of what you just talked about. This is a patient, Elaine, 40-year-old female. Chief complaint, deep, dull, aching, throbbing pain in the upper left back teeth area. Started about 5 years ago. It's intermittent, lasts anywhere from 4 hours to several days, can cause her to miss work. On a severity scale, she will say 0 being no pain, 10 being the worst pain that she can imagine. It averages about 7 to 8 out of 10, and it can get to a 10 out of 10. So we always want to know who our patients saw before they came to see us. We also like to know what kind of treatments they had. So Miss Elaine saw a general dentist, an endodontist, a TMD practitioner, not an orofacial pain specialist, oral surgeon, chiropractor, massage therapist, and a neurologist. And then she has been trialed on an occlusal splint, neck adjustments, massage, and carbamazepine, which is often used for neuropathic pains that you'll hear about in a little while. So her past dental history is non-contributory. Her medical history, she says sinus headaches run in the family. We should all know that sinus headaches are very rare, unless they're blowing, a bunch of green stuff coming out their nose and their mouth. It's probably not a sinus headache unless we see pathology. Most people with sinus headache tend to have migraine. So this particular pain is aggravated by exercise and stress, some relief with NSAIDs, and then she also has nausea, light and sound sensitivity, nasal congestion, and neck pain that seems to occur with her pain. So I think we all know where this is going, right? What is this? Migraine, yes. And we see most everything is normal on our exam. Some of her mastoid muscles, primarily her temporalis muscles, were a little bit tender to palpate. Some of the cervical muscles were tender to palpate also. We shouldn't let this fool us. We need to take this all with a grain of salt. This tenderness to palpation could be what you heard about earlier, some of that referred, some of that wind up in the central nervous system. Okay, so we know our diagnosis already. So when we look at non-odontogenic facial pains, one of those is various headache disorders, and that's what we're going to talk about for a little bit today. Now, a good friend of ours, Don Premack, used to say to his residents, headache is not a diagnosis. So when you ask, what is this? Yes, it's a type of headache, but headache in and of itself is not a diagnosis. So where do we look for classifications? The most commonly used is going to be the International Classification of Headache Disorders, the most recent edition in 2018. and this was published in Cephalalgia again in 2018. And you can see it breaks down the primary, the secondary, and then some other types of headaches too. So for our talk, we're just going to talk about the primary headaches because we could talk for days about all the other types of headaches. And you'll learn that in some of the more advanced courses that you might take. So what are primary headaches? Well, they have obviously no underlying cause, although a lot of the primary headaches may have common symptom presentations. They may have very similar pathophysiology, and they may respond to the same therapies. So why is this important? You're thinking, I'm a dentist. Why is this important? Well, a lot of headache complaints, or a lot of complaints of orofacial pain, may be related to a headache disorder. So what is migraine? Well, it's painful. We know that. It can be disabling to a lot of folks. It's inherited, and it's a brain disease. Migraine is not just the headache. Migraine is the whole brain that doesn't adapt well, basically. It's characterized by neurologic, sensory, autonomic, vestibular, cognitive, and gastrointestinal symptoms. About 47 million people in the U.S. have migraine, 10% of school-age children. There is a hormonal component for a lot of individuals, and vasodilatation is not necessarily sufficient for migraine symptoms to occur. We used to think this was primarily a vascular disorder, but it's not really. It's more neuroinflammation of some of the central and peripheral nociceptors. So a very simplified diagnostic criteria that was proposed by Lipton and his group in 2003. If a patient says they have a headache and they have light sensitivity with it, if they feel nauseated or their stomach is upset with the headache, and they have a decreased ability to function, any two of those three would say this person has migraine. And in fact, if a patient comes to you with a complaint of a headache, it's probably migraine. Most people don't complain of other types of headaches, especially episodic headaches. So we can look at the prevalence. We can see that the female sex is going to be in the red, and the male sex is going to be in the blue. The distribution is about the same, although females tend to have it more, and we're talking about biologic females, biologic males, tend to have more than males. But you can see the prevalence peaks about the same for both sexes and then begins to decrease as the person ages. Migraine has 4 different parts. And maybe you've heard of some of these. Maybe who has migraine? Anybody? Okay. Most people that go into orofacial pain or headache medicine have headaches, and we can all relate. So the first part is the prodrome, and we'll talk about these specifically in just a minute. Then comes the aura, and then comes the actual presentation of headache, and then we get the what's called the postdrome. So to kind of further define those, the prodrome is going to be symptoms that begin before the onset of a headache and can actually warn the person that a migraine attack is about to come. And it's usually about 2 to 48 hours before the migraine attack occurs. Some of the symptoms might be tiredness, yawning, increased frequency of urination, impaired concentration, neck stiffness, mood changes, increased thirst, food cravings. Food cravings is part of the process. So a lot of people, they say, I get migraine after I eat chocolate. Well, what is the number one thing people usually crave? Most people, not everybody. Some of you sickos don't like chocolate, but so most people crave sweets or chocolate, and they say every time I eat, chocolate, I get a headache. Well, they're probably going to get the headache anyway. So sometimes you tell them, just go ahead and eat the chocolate because it's going to occur. That's probably part of the prodrome. And then some autonomic symptoms that maybe they notice more draining in their nose, maybe their eyes start watering, maybe they start sweating, things of that nature. Now, the part of the brain that's responsible for the prodrome is thought to be the hypothalamus, the brainstem, and the cortex. The aura phase. Not everybody has aura. About 30% of the population will experience an aura. These are going to be transient, reversible neurologic deficits, about 5 minutes to an hour, usually, again, before the onset of headache, although they can occur concomitantly. They can be several different manifestations. It can be visual. So it can be what we call positive. And since there's no migraine people, or very few in the audience, you probably don't know what this is. But a positive would be something in the field of vision, or seemingly in the field of vision, whereas negative would be patients always, will say something like, I just lose vision, everything goes black, or there's a little hole in my vision, I can't see the TV screen around it. And some people have both of these. Some people can also have sensory deficits, or symptoms, motor symptoms, like they might get numb, they might lose the ability to do certain things. They can have speech disturbances, and we've all seen in the news people that, on camera they start stumbling over their speech and everything. These used to be called brainstem symptoms or basilar migraine symptoms, and then sometimes retinal disturbances as well. The aura phase is caused by what we call cortical spreading depression, or more accurately, depolarization, spreading across the cortex. This is not necessary to trigger a migraine, but it is necessary for the aura to occur. The part of the brain that's responsible for the aura is thought to be the cortex. So this is a picture that it's kind of interesting. I'm glad I saw it early on in my career, because I didn't start getting aura until my 50s, and I grew up with having really bad migraines, never had an aura. And then in my 50s, I started getting these. And you can see what we call a scintillating spectrum that will start usually in one side of the person's vision and then progress all the other side. And what's interesting, you can close both eyes and it's still occurring. If it's only in one eye, we call that a retinal migraine, whereas at both eyes, it's going to be the scintillating schemata. Now, the schemata is that part of the vision that goes blank. And so, like in my case, it starts out where I'm just kind of looking around and I'm like, when did I stare into a light? Because it's like that, you stare into a light thing and then you get that little bright thing, and then I go, oh, okay, I see it coming. And within about 45 minutes, it's gone, but it just kind of spreads this, this absence of vision along with the flickering lights that, again, I'm glad I saw this early in my career. Otherwise, I would have thought I was having a stroke. And people get pretty freaked out when they first encounter one of these, because it is so weird. So the cortical spreading depression, or depolarization, usually occurs in the occipital region and progresses very slowly anteriorly through the cortex at about 2 to 6 millimeters per minute. So it's a very slow progressing wave. I tell patients it's like this wave of electrical activity that's stimulating a depolarization of those cortical neurons. So the headache phase then follows. Now, some people will get a aura only, and that's what I started getting more recently. As I said, well, it's not been recent anymore, but in my 50s, I would get the aura without the headache. So now I get more auras than I do headache. The duration of the headache phase is going to be 4 to 72 hours, kind of like the patient I showed you, Miss Elaine. Her tooth pain lasts about 4 to 72 hours. They're mostly unilateral. They throb or pulsate. They're moderate to severe in intensity, and they are accompanied by nausea and or vomiting, and or photophobia and phonophobia. That means intense sensitivity to light and sound. So they can have both of these, or they can have one or the other. If they have the light sensitivity, then they need to have the sound sensitivity as well. Migraine is a type of headache that is actually aggravated by physical activity. So migraine patients will seek to go into a dark space, a quiet space, and just lay really, really still, because even just the simplest movements bending over, doing certain tasks, just exacerbate the headache tremendously. Now, about half will have bilateral, again, what we call autonomic symptoms. And this can be tearing of the eye, it can be redness of the eye, it can be sweating, it can be nasal congestion and drainage, things like that. It's bilateral, though, and that's an important determinant, important feature. So the part of the brain for the headache phase is going to be the trigeminal vascular system, the brain stem, the thalamus, the hypothalamus, the basal ganglia, and the cortex. And then the postdrome phase. This is also characterized by sensitivity to light and movement, lethargy, fatigue, difficulty focusing. People just say, and if you've had migraine, you just feel zombie-like, like you've got a hangover, something like that. You just don't feel yourself. The duration can be a few hours to even up to a few days with this particular phase. We don't necessarily know the brain area involved at this time for the postdrome phase. So again, migraine toothache. Primary headaches will sometimes present as tooth pain. And this, again, Dr. Nixdorf and Aurelio Alonso published this back in 2006, and then it's been published more recently as well, of cases where tooth pain will feel like or tooth pain will actually be a headache. So I tell our students and our residents, if a person comes to you with a toothache and you can't find anything wrong with the tooth, first thing you do, as you heard earlier, is start palpating muscles to see if there's any trigger points, any myofascial pain with spreading causing tooth pain. But then don't try dental therapies. I hear way too often, we couldn't find a definitive problem, so we tried a root canal on tooth number 3 or whatever. Don't try therapies. Be sure of your diagnosis. The pain with this may be spontaneous, variable, pulsatile, like pulpal pain, so it can trick you there. It can become quite severe, 10 out of 10 on a visual analog scale. And then the patient will often experience complete remission, similar to a migraine. So for 4 to 72 hours, they have tooth pain, and then it goes completely away, which confuses the patient and confuses the practitioner. Also, the pain may go away for a period of time after dental therapies, which is also confusing, and it lasts 4 to 72 hours. Doing diagnostic anesthetic blocks can sometimes alleviate the headache or the toothache, but not always. So it's what we call equivocal. So they're actually, the International Classification of Headache Disorders does not list this in their classification, but the new-ish classification system, the ICOP, does mention it as a presentation, and this would be orofacial pain resembling presentations of primary headaches. So you can refer to that. That was also published in Cephalalgia in 2020. So again, we get back to Elaine. We know now, because of some really well-done talks earlier, that this is migraine. The characteristics are deep, dull, aching, throbbing. Pain lasts 4 hours to several days, can cause her to miss work, which migraine can. Sinus headaches run in her family. It's aggravated by movement, like exercise, also stress. NSAIDs are some help. Sleeping is helpful. Often these patients will say, usually if I go to, in a dark room, quiet room, and sleep for a period of time, it goes away. Our patient also had nausea, light and sound sensitivity, nasal congestion, and neck pain. So how do we treat these patients? Primarily, we want to reduce their pain and restore function, quality of life. I mean, that's all we want to do in orofacial pain practice, is try to alleviate the pain the best we can, manage it, and then restore the person to a good quality of life. We also want to prevent the progression of the episodic migraine into more of a chronic migraine, which can occur about 2.5% per year. So, patient education. As with any entity, that we face in orofacial pain. We want to educate our patients. This is often the first explanation a patient will receive as to what's going on with them, and they're so grateful. We can see a patient, we can do our complete workup, we can consult with them and do absolutely nothing as far as therapy, and they will go, because they a lot of times come in very stressed, very anxious, sometimes tearing as they talk about it, and they leave smiling, and you're thinking, I didn't do anything. Yes, you did. You gave them information, you gave them a plan, and it may not include you, it may include a referral, but you gave them information as to what's going on with them, that it is real, and you gave them a plan, and that's often the first experience like this a patient will have. So we educate our patients, we talk about lifestyle modifications and avoidance of triggers. So what is that? Regular bedtime, good hydration, good nutrition, just things to avoid stress on the system. People with migraine don't tolerate stresses very well. Our brains are very sensitive. That's why, somebody like me, and don't try to be like me, but some people like me can walk out in the hallway, and if somebody's wearing a particular perfume or fragrance or something, man, it just almost knocks me over because I'm very sensitive to things like that, whereas everybody else is like, I don't smell it. So we talk to them about, just avoiding certain things. A lot of headache clinics will ask patients to not wear scents into the clinic because other patients are so sensitive. At our American Headache Society meetings, people are asked to not wear scents because, again, most of us have headache. And then we approach it with appropriate pharmacotherapy, both abortive, in other words, here's something that will get rid of the pain in a reasonable amount of time, and then, if necessary, preventive, to prevent the frequent recurrence of the presentation. It's not one size fits all. In dentistry, don't we just love cookbooks? We love, I'm going to do this first step, I'm going to cut this prep this way, I'm going to put this material in there, and then I'm going to seal it with this and whatever. Sorry, I haven't done restorative dentistry in a very long time. But, gadgets and potions and things like that. We love that. We want a step-by-step. Orofacial pain is not that way. Everybody's different. We have to approach it different. That's what I love about it, because every day is something different and something new. So as far as abortive, triptans, when they came out in about 1991, these are serotonin 1B, 1D receptor agonists. They became the standard of care for many, many years. And when they first came out, to me it was like a miracle drug, because it was something I could actually take, and at the time it was injectable. I didn't care. I could take it, abort the headache within about 30 minutes to an hour, and not feel drugged. Before that, it was medications that, like opioids and things like that, made you feel very drugged, feel very bad, couldn't go back to work. So these were lifesavers for a lot of us. But most studies would say only about a third of patients are pain-free at 2 hours. I was fortunate to be one of those. Discontinuation rates are pretty high with the triptans. Some people feel like they get significant side effects, and they do have some cardiovascular risk that we need to use with caution because of the serotonin agonism. In 2018, the new classification of CGRP, or calcitonin gene-related peptide receptor antagonists, were developed and put on the market. We call these the GPANTs. And then in 2019, a new serotonin, a 1F receptor agonist that doesn't affect the vasculature, has become available as well. So when do we think about preventatives? Well, if the attacks are significantly interfering with the patient's day-to-day activities, we want to consider maybe they need an abortive or a preventative to help them with that. If the frequency of attacks is occurring more frequently, if they have a contraindication to or failure of the acute treatments, if the adverse events with the acute treatments make it non-sustainable for the patients, and then bottom line, patient preference. If the patient desire something to take on a daily basis to prevent the number of occurrences, we have to consider that. Everything we do, we want to consider the patient. So for preventatives, again, some of the CGRP type agents have become available for preventatives, and these are the monoclonal antibodies, or the mAbs. Also, there's a couple of the receptor antagonists that can be used for both preventative and abortive. Some of the older ones, some of these that I initially tried, beta blockers, can make people feel lethargic and depressed. Anticonvulsants, antidepressants can be used. Calcium channel blockers, angiotensin blockers, NSAIDs are sometimes used as preventative agents, although they can cause what we call a medication overuse headache. Triptans in some cases, are the long-acting ones, are used as preventatives. Botulinum toxin, or Botox, and others you've probably all heard about. And then there's alternatives and supplements that can be used as well. So, kind of the bottom line or the takeaway, we've got a lot of options, but our patients are all different. And so one is not going to work for everybody. And so we need to have a bunch of tools in our toolbox and be willing to discuss all these with our patients. It's like I tell our students, we may not use all these. It's kind of like sleep dentistry. We don't, prescribe CPAP and things, but we need to at least discuss these with our patients so that they know they have options. And again, it may be the first time they've heard that they have options. So now let's look at tension type headache. So tension type headache's usually a little lower in severity as far as the pain. It's not associated with nausea and vomiting, but some patients may have photophobia or sensitivity to light and sensitivity to sound. Tension type headaches are not generally aggravated by activity. The pain is more pressing, tight, like a tight squeezing band around the headache as opposed to a pulsing, throbbing type. It's usually bilateral in the temple and occipital areas. Patients will often say, it just feels like a band around my head. The pathophysiology is unclear. It used to be thought that, and these used to be termed muscle tension type headaches. But we know that muscle tonicity is not really a factor in these particular types of headaches. Patients will have pericranial tenderness. You palpate around and they have tenderness, but the muscle tension is not the pathophysiology. It may be part of it, but it's not the complete picture. It could be a genetic component, although that's not as strong as we saw in migraine. And psychological factors like stress play a significant role, especially in the chronic patients. And so, again, when I start bringing up psychosocial factors to our dental students, I say, if you're like me, you hear psychosocial and you're like, oop, I'm out. I'm a dentist. I don't care about their psycho or their social. They can deal with that on their own. If you're going to get involved in orofacial pain, and our students may not, but I tell them, if you're going to be involved in patient care, you need to know your patient first. And especially in orofacial pain, we need to understand that there could be significant psychosocial. Think about it. Everybody's got PTSD today. You might say, no, I don't. Well, maybe you don't. But think about the news. Think about these. Think about, every minute we're getting a mass shooting pop up on our phone. It doesn't have to be stressful to us or traumatic to us, but if it was to the patient, then it is. And so a lot of our patients, I say that to just reinforce, a lot of our patients are going to have psychosocial components to their pain. A lot of people these days are going to have post-traumatic stress. And we need to be acutely aware of that. We need to understand some people are struggling to pay their rent. Some people are struggling to pay their grocery bills. And it's a good thing, again, to get to know your patient and understand that. So tension type headaches are the most common headache presentation. They affect women a little bit more than men, like migraine is a little bit more in women as well. The average onset is going to be in about the third decade, age 25 to 30. It's going to peak around age 40. How do we know? Well, we need a comprehensive history. So it's important, again, with all these entities in orofacial pain to get a really good history. We can't just jump into the exam and then make a diagnosis. We can a lot of times, though, make a diagnosis from the history. So we have like a 20-page packet that we give our patients, and people are like, why so much? Well, I can almost make a diagnosis from that form that I try to get from them a day or two in advance. So pain diaries can help us too. There's two types, episodic and chronic tension type headache. People with episodic tension type headaches are usually not going to complain to you. In fact, they won't even tell you unless you ask, do you get any headaches? Occasionally. Well, it's no big deal. That's episodic, and it's usually tension type. Whereas chronic tension type headaches are going to be associated with more disability, more comorbidities, and more difficult to treat. Anxiety, depression, stress, all these different entities are common comorbidities, and it's often associated with neck and back pain as well. So how do we treat them? Well, pharmacologically, we might try NSAIDs, and in fact, they're usually the first line of treatment for tension-type headache. Combination analgesics are maybe second line, and these are not the opioid combination analgesics. These are not the butalbital-containing analgesics like Fioricet and some of these others. These would be combination analgesics with caffeine. The others, the opioids, the butalbital, contraindicated. Don't use those. Low-dose tricyclic antidepressants can be a first-line treatment for prophylaxis. I need a beer. No. That's it. It's all good. For chronic tension-type headache. And then non-pharmacologically, cognitive behavioral therapy can be very effective. So it's good to get to know, and unfortunately I don't know one in my area, but a clinical psychologist that has specialty in pain. They can give them the tools to help manage these very effectively, especially in pediatric patients. Biofeedback can be very useful, mindfulness. So we do talk to our patients about incorporating mindfulness into their daily activities. We want them to actually set a timer, and part of it's for the presentation of daytime parafunctional behaviors. But I tell them that this is your mini meditation. This is where I want you to focus on your breathing, focus on your posture. If you pray, say a prayer. If you like nature, look out the window. Do something to break up your day that's for you. And it can be just a couple minutes, but do something. Acupuncture can be helpful. Physical therapy, especially people with comorbid neck and upper quadrant pain. There is very little evidence that our beautifully made and articulated oral appliances have really much benefit for tension-type headaches. Now, another patient, maybe you won't get this one so quick, maybe you will. 35-year-old male, headache and sinus pain, referred by ENT because they saw no sinus pathology for atypical facial pain. So the location is the left orbit as well as the temporal and left maxillary areas. So we have a diagram in our packet, and I want patients to diagram where their pain is. I want them to tell me, does it spread anywhere, with arrows and things like that. The really difficult when you know you're in for a long appointment is when everything is blacked out and they use different pencils and different hash marks for their pain. And it's just like, okay, where do we start? So Jim says that his pain began about a year ago, has remained mostly unchanged over time. It seemed to start after he had a dental implant in the left maxilla in the posterior region. So we want to know what the pain feels like. It's a good idea to use different tools like the McGill Pain Questionnaire because it does provide a list of descriptors, but we want to know what the pain feels like. You know, if somebody says it's electrical, it's burning, that could be nerve-related pain. Pulsing, that could be vascular, that could be pulpal, that could be migrainous type pain. Well, Jim says it's severe, shooting, aching, splitting, grueling, intense, piercing, aching, sometimes sharp, stabbing, like an ice pick. So a lot of different descriptors. And you may think, well, grueling, that's not really a pain descriptor. That's what the pain is doing to him. It's grueling. So we need to know these things. We also want to know how bad is the pain. And in Jim's case, it's a 9 to 10 to over 10. He's unable to focus. It causes him to stop whatever he's doing. If he's driving, it causes him to stop and pull over. It will awaken him from sleep. When the pain is present, he feels very restless and he has to pace the floor. Remember, migraine people don't want to get up and move around. So there's a difference there. So we also want to know the frequency, how often does it occur, how long does it last, when does it occur? Well, for our patient Jim, 2 to 8 times per day, lasts anywhere from 30 minutes to an hour, usually during the day, but can also occur during sleep because it can awaken him from sleep. It comes on for about 2 to 3 months, then goes away for a while. We want to know, how did it start, what makes it start, what makes it worse, what makes it better, and does anything happen with it? Well, Jim says it seems to come on after drinking some alcohol. However, during the periods when the headache's not there, the alcohol doesn't bother him at all. He can drink his normal amount. There's nothing that really makes it worse. When it is bad, ice helps a little bit. He also tries to press real hard on the area, or sometimes he actually uses his shoe and bangs on his head to help alleviate the pain. It's very temporary, but he said it does seem to work a little bit. He does have some left eye tearing and swelling and redness, some sensitivity to light just on the left side, nasal congestion on the left side, and sometimes he sweats on the left side. So what other things might be important? Well, I'm not going to put you on the spot. Previous consults and treatments, he did see a family physician, a neurologist, a chiropractor, ENT, and general dentist. And remember, the ENT referred him to you, the orofacial pain specialist. The ENT did prescribe a corticosteroid nasal spray. The neurologist prescribed oxcarbazepine, which is an anti-epileptic that we use for neuropathic pain. Verapamil was also prescribed. Prednisone taper seemed to help a little bit. So he's well-controlled hypertensive and hyperlipidemia. He does have poor sleep, but only during the headache phase. He's married, 2 children. He is an investment advisor, and he drinks 1 to 2 beers per night just to help him unwind. He says he might grind his teeth during the day, but he's not sure. Jim's examination is pretty much normal. Vitals are normal because he's well controlled with medication. Everything that we look at is normal. Muscle palpation, everything. And you can see the upper left, the implant there. Obviously we'd say, well, is there something in the maxillary sinus there? No, the maxillary sinus is clear. Again, he did see an ENT who imaged the area as well. Anybody know what this is? Cluster. You get absolutely nothing, but that's correct. There is no prize. That's just the way I work. I should have, but I'm not that nice. Marcella probably brings prizes. I don't. So we'll just pretend like you didn't get it right, and we'll say, could this be a migraine variant? Well, it doesn't fit. The duration is much shorter than the 4 to 72 hours. With migraine, you're going to have bilateral photophobia and phonophobia, or photophobia. Nausea and vomiting, and/or vomiting is not present in Jim. Migraine patients, again, usually want to go to a dark, quiet, still environment, and that's not what Jim does. So could this be a TAC, a trigeminal autonomic cephalalgia, which cluster is part of that class? These are characterized by usually very short-lasting head pain with cranial autonomic symptoms, tearing, nasal rhinorrhea, running, redness, sweating, things of that nature. So in that category, there's cluster, paroxysmal hemicrania, SUNCT, which is short-lasting unilateral neuralgia form, blah, 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 and then SUNA, which is another the shorter the duration of the headache, the longer the name. Just consider that. Yes. And as we know, when classification committees get together and form new terminology, the names get longer, which really sucks for me because I struggle with big words. So I think it's a Texas thing maybe. So with a cluster, the attacks are going to be severe, strictly unilateral. A lot of people will describe it as the worst pain they can imagine, the suicide headache, because they can't imagine pain any worse. The pain is usually going to be orbital, supraorbital, temporal, any combination. If you remember Jim's diagram, that's what it was, periorbital, supraorbital, and temporal. They last anywhere from 15 to 180 minutes. It will occur once every other day, up to 8 times a day. There tends to be a circadian periodicity, and they tend to be seasonal. That's why they call them cluster, because they occur in clusters during different seasons. And then they tend to occur at certain times during the day. That's circadian periodicity. Vasodilators can trigger the attacks, but only during the cluster period. So if a patient is not in their cluster period, they can drink alcohol and take vasoactive medications or supplements and be just fine. But then during the cluster period, it can trigger the headaches. This is one that tends to occur more in males than females. Usually it will start in the in the 20s. The traumatic aspect, some patients will develop a post-traumatic cluster headache. In this case with our patient, it could be related to the implant, but that might just have been an incidental occurrence. Again, it's very excruciating. They'll say it's like a hot poker. They'll describe it as somebody ripping their eye out or stabbing them in the eye or poking them and moving the knife around in their brain. It's very, very intense pain. They become restless. They pace a lot. Patients will bang their head on the wall. They'll use a shoe to the point where they'll actually cause bruising and bleeding in some cases, trying to alleviate the pain. Remission can be months to years. If it's chronic, there is no remission. If they do have any remission, it's shorter than 12 weeks. So again, this is just a picture that delineates some of the autonomic features. And one that I haven't mentioned is ptosis. So we get a partial ptosis of the eyelid or drooping of the eyelids, maybe even the brow, and the rhinorrhea, the runny nose, the sweating, all on one side. It's very unilateral. So again, why is this important in dentistry? Well, migraine, trigeminal neuralgia, sinusitis, odontogenic pain, and TMDs are the most common misdiagnoses. So a lot of patients will seek out dentists and actually receive dental care. Patients frequently consult a dentist. In this particular study, 45% of the subjects with cluster headaches were examined by a dentist before receiving the correct diagnosis. And they also had some misappropriate or inappropriate dental care as a result of that. It's not terribly uncommon for them to lose teeth before they get a correct diagnosis. 42% in this particular study, not a lot of subjects, had some irreversible procedure done. So, should we do any testing? Smarty pants. Any testing that you would want to do in a cluster patient? MRI. Maybe. No, we would. We would want to get an MRI of the brain to look for certain things, but obviously we want to see what's happening in the pituitary. In this particular study, they found that a significant number of patients had vascular problems, some had tumors, and then there was also inflammation and infection. Again, no prize, but well done. So some other things we might want to do. A beer? No, that's for me. I'll tell you about my beer, but that's it. Anyway, so I like to get sleep studies because, and this is by no means original work by me, just looking at a lot of studies though, I found out, hey, cluster seems to tend to occur with sleep disorder breathing at a pretty frequent rate. Testosterone levels. We know that low serum testosterone is reported during the active cluster period compared to inactive periods. So there is some data for testosterone replacement therapy in some of these individuals. So with treatment for cluster, we're going to look at acute abortive treatments, which are few, bridging therapy, because we know that if we're going to start a preventative, it's going to take it a while. And so we give patients a bridge between the acute and the preventive. And then ultimately preventive therapy for those with chronic or frequent recurrent cluster. Oral medications are not good for cluster because by the time it starts working, the headache phase is done. Again, it's about an hour in duration, maybe 90 to 180 minutes. High flow oxygen has really good data, 100% at 6 to 15 liters per minute. But interestingly, insurance really doesn't cover it very well, especially Medicare. Triptans that are injectable or intranasal because they work really quickly can be beneficial, and then stimulators. And there's external vagus nerve stimulators now that, again, it's just a handheld device that stimulates the vagus nerve that can be used acutely and as a preventive. The sphenopalatine ganglion stimulator was a surgical procedure to put it in that kind of went bankrupt for a period of time, but I think we're going to see it come back. So a surgeon would put a stimulator in at the sphenopalatine ganglion, and then an external device can be turned on to stimulate it. So as far as preventative, the best evidence currently is for verapamil and lithium. There are some open trials that would say topiramate or Topamax, gabapentin, valproic acid, and even melatonin can be used for preventative. For episodic cluster, Emgality is easier for me to say, which is a new CGRP monoclonal antibody, may be effective. So it did get FDA approval for episodic cluster. So what do? I diagnose the best I can. I do consult with the patient, let them know what it is, as best we can, why. I do get imaging, unless the insurance carrier won't cover me ordering it, or I tell them go to your primary care, and if the primary care says, no, I'm not going to do it, then we go ahead and make the referral before the imaging. I might initiate occipital nerve blocks. These have also been shown to be effective as an abortive and to some degree a bridging therapy. So at the occipital nerve branches, we might use a local anesthetic with a small amount of a corticosteroid. Ultimately, though, I'm going to try to refer them to a headache fellowship-trained neurologist because they're going to be probably, in my opinion, now there's some orofacial pain specialists that do a great job with cluster, but I've found the older I get, the less I want to do. No, just kidding. I like to stay in my lane, and so I feel the patient is best served if they see a headache-trained neurologist. So do we test for primary headaches? Most of the time we don't need to do any specific diagnostic testing. Our good comprehensive history and physical exam can give us a preliminary diagnosis. Blood tests are usually not needed unless you suspect something like a vascular issue like temporal arteritis or giant cell arteritis. Neuroimaging, the chance of finding some kind of pathology in most primary headaches is really low, with the exception of cluster. We want to image cluster. And it depends on a normal neurologic exam. And so as an orofacial pain specialist, you will want to do a cursory neurologic screening and a cranial nerve screening as part of your routine. Now, the European Academy or Headache Federation does recommend MRI for all TACS. So kind of my baseline is all suspected TACS, I image, and then any potential neuropathic pain that you'll hear more about. There are some red flags. The P's have increased in this since the initial snoop, but these are some of the things that would make you want to image or refer. Systemic symptoms, any neoplasm history, neurologic deficits that you see in your examination. Is this headache a very abrupt onset? Did it just come out of the blue with no previous history of headaches? Is it an older patient? Has the patient's headache pattern changed dramatically recently? Is it postural, positional, coughing, sneezing, exercise? Does that make it work? Papilledema, which I'll show you an example of in the next slide. The optic disc will swell. New onset headaches during pregnancy or other headaches during pregnancy. Painful eyes, post-traumatic onset, pathology of the immune system like HIV or something like that, and somebody that has overused some pain medication. So what is papilledema? So another tool in the orofacial pain specialist toolbox is looking in the eyes. So, we get outside the dental range, we look in the ears, we look in the nose, we look in the eyes. And so with an ophthalmoscope, we're looking, and a lot of patients say, I've had cataracts, and I say, I don't care. No, I don't say that. Sort of, I say I don't care. But I say I'm looking at the back of their eye. What are you looking for? Well, I'm looking to see if there's any swelling inside that space that might cause changes. And so you can see on the left side, as you're standing there, that optic disc is blurred. So swelling in the intracranial space is pushing to cause that increased pressure and that swelling. On the right side, that's a normal disc. I use a device called a panophthalmoscope, which is like cheating, really, because it's like this binocular thing that you just rest on the eye, and you don't have to kind of look around that much. It's just there. It's like a big picture. But that's something that an orofacial pain specialist should be looking at, especially in headache patients. So to wrap up, headache is common, and it'll be real common in the orofacial pain practice. People will ask me, do I see migraine? Yes, I see a lot of migraine. And it might not be the initial referral to me for headache, although I do see a lot of that. But a lot of times we see headaches that patients have, and maybe they're being undertreated, maybe they're misdiagnosed, and it's up to us to make an appropriate diagnosis and then prescribe the most appropriate therapy. So it is a common presentation. It can mimic dental pain. It can mimic temporomandibular disorders. Good history, good physical exam. So becoming familiar with the headaches and with classifications. We think, oh, classifications, that bores me. We need to not necessarily recite them unless you're a resident, then you will. But we need to understand the classifications. Why? So we can talk with our colleagues, but more importantly, so we can talk to our patients. This is what I suspect you have. And even though it's a big name that I can't often pronounce, I try to muddle my way through it, and they're relieved. Everybody else has just looked at me like I don't know. It's all in my head. Well, yeah, it is, but it's a real thing, and it just happens to be in your head. So we need to know the classifications to a degree where we can intelligently talk with our patients, and we need to help our colleagues avoid unnecessary, well-intentioned, misguided therapies. So that's all I got.